be live.
Alrighty, and you let me know when to begin.
I believe we are live now. So, hello, WebShadowers. Welcome back to our third session for Spring 2021. For those of you who haven't attended this semester yet, we've updated our guidelines a little bit. You will now have to sign into a Google account to fill out the Google Forms. This means that if you don't already have a Google account, please make one soon. They're very quick and easy to make.
Along with requiring sign-ins, we've added one more question to the Google Forms, making it a total of 4 questions now. So to earn credit for the session, you must at least earn a 75% or answer 3 out of 4 questions correctly. And also please remember that your sentences in the summary need to be at least 3, and please write well-written ones. Finally, WebShadowers is adding a marketing position to our team. So if you're interested in joining our team, please create a physician presentation post for us or a previous design you've already made and send them to us on Instagram. Throughout this week, we'll be reviewing the submissions.
And as always, please remember that the Google form will be posted in the chat box at the end.
Now, with that all being said, today we have the pleasure of hosting Dr. Ramadan, a pediatrician who will be teaching us today. Dr. Ramadan, you may start whenever you're ready.
All right, hi guys. Again, I'm super excited to be here. I think this is such a wonderful opportunity, especially during these really odd times. And I'm just so overwhelmed and excited to be sharing with you guys my love for pediatrics. And I hope that this session can be informative and interesting, and we'll try to make it fun as well. So let's see. A little bit about me. I went to undergrad at the University of Texas at Arlington, and then I went on to do my medical school at Texas Tech University Health Sciences Center. And then I did my 3 years of pediatric residency at Baylor College of Medicine. So for the past 11 plus years, I've been in Texas. Currently, I am a board certified general pediatrician, but I work as a newborn hospitalist. So I only see newborn babies, and I am going to be sharing with you guys kind of what my typical day looks like, and we'll be kind of virtually rounding on patients. So I hope that this is fun. We'll try to make it really interactive. So use the group chat to pitch in your answers, questions at any time, and we'll try to make it as fun. So newborn medicine, honestly, when I was in your place, I didn't really know that there was a designated position just to see newborn babies, right? So many general pediatricians will work in the clinic, and then some will go out to the hospitals and see a couple of babies. But for me, I am a dedicated newborn hospitalist, which means I do not work in the clinic. I work at a hospital at the Well Baby Nursery, and I only see newborns. So what is so special about newborn medicine? Well, we're usually the first doctors to examine a baby, and we'll see how that could be really important. Some of us do attend deliveries, and we are there to provide resuscitation for certain newborns that need a little bit of help during transition. We perform routine newborn care, which we'll talk a little bit about. We work very closely with many different medical specialties like cardiology, urology, nephrology. We work closely with our NICU team, of course, as we are able to, tell if a baby requires higher level of care and be able to consult them for certain things and be able to transfer baby to the NICU if need be. We also perform procedures. So we do male circumcisions, we do lumbar punctures, and my favorite part has to be providing anticipatory guidance. So you have a lot of first-time moms, you have experienced moms, and honestly, this is the time where you have to kind of give them a good base knowledge, because newborns don't come with an instruction manual, right? That would be easy, but that is why we need pediatricians. That is why a newborn hospitalist is really important, because we are able to talk to parents about lots of safety, things to expect, to make sure that babies are safe when they do go home. So that is my quote right there. And that is actually my daughter. I had my daughter during residency training, and she's now almost 3 years old. All right, so like I said, I'm gonna try to make this really interactive. We're gonna pretend like we're rounding in the hospital, and I'm gonna take all of you with me. And so let's imagine, I usually get to work around 8 o'clock in the morning. And at the hospital that I work with, we see maybe about an average of 25 babies a day. It does go up. I've seen 30 plus babies, and now during COVID and the pandemic, there are actually a lot more babies. And so we have been seeing a lot of babies recently. So let's pretend we're at the hospital. We're gonna start our rounds. We got our sheet from the nurse. It has all of the babies that we're gonna be seeing. And we are here at room 204, and we're knocking on the door, and we're about to enter. So first we're gonna see baby boy A. And this baby is 40 weeks gestation. So baby was born at 40 weeks. Baby is LGA, which stands for large for gestational age, which means baby's weight, birth weight, is more than the 90th percentile. So out of all the babies that are born at 40 weeks, this baby weighs more than 90% of babies born at this time. He's a male, and he's born to a first-time mom via forceps-assisted vaginal delivery. And forceps are instruments that are used during a difficult delivery to help get baby out. And unfortunately, the delivery was complicated by something called right shoulder dystocia. And again, that is when there's a difficult delivery and baby's right shoulder was stuck under mom's pelvic bone and had a rough time coming out. And again, pregnancy was complicated by GDM, which is gestational diabetes mellitus. So mom had diabetes during the pregnancy. So that's a little bit of history about the baby. But when we go in to examine, we're talking to mom, we notice that baby's not moving the right upper extremity. What do you think are some of the red flags, just based on the small history that I told you, that can give us clues as to what may be going on? And you guys can feel free to type in your answers in the group chat. All right. And I may not see everything on time, but gestational diabetes, yes, excellent. Nerve damage, absolutely. Paralysis, right, baby's not moving the right arm. Gestational diabetes. And why do you guys think gestational diabetes is a risk factor? So with gestational diabetes, babies are they are more likely to be large for their gestational age. And when babies are large, they can sometimes have a rough time coming out of the vaginal canal. So being large for gestational age, having forceps assisted vaginal delivery, having the right shoulder dystocia or the right shoulder being stuck, and gestational diabetes are all red flags. So what happened to baby is something called a brachial plexus injury. And you may hear it kind of on the, during like commercials and things for like lawsuits and, a bunch of that. But basically what happens is, it's really interesting. So you have a brachial plexus, which is a collection of nerves that you can see from the photo is between kind of where the neck is and the shoulder. So there's a collection of nerves there. And you can see that if there is any trouble with allowing that shoulder to come out, some of those nerves can be injured. And what happens is some of the nerves can be stretched, and we call that neuropraxia, as you can see from the screen. If they stretch too far apart, they can actually rupture and they can be torn. You can also have what we call an avulsion. So they tore kind of where they start and originate from the spinal cord. Or you can have something called a neuroma, and that's when scar tissue and swelling forms around the nerve, and that doesn't cause the nerve to function properly. So what do you think will happen? Well, the nerves aren't really gonna function properly. And depending on what those nerves do, you're gonna have symptoms. So many of those nerves will control muscle function in the chest, in the shoulders, in the arms, the hands, the feeling of sensation in that upper limb. And so anything that happens to those nerves will cause those types of symptoms. All right, so on our exam, you can see that baby is not moving one of his arms. You can also do a Moro reflex, and that's when you kind of drop baby's head a little bit, and babies will do this. If you find that it's asymmetric and one side isn't moving, then that could be also an indication. Something that is really interesting, and I actually saw this a couple of days ago, is that you can have something called Erb's palsy. And what that is your C5 and C6 nerves are affected, and what happens is that arm is going to be adducted, so meaning close to baby's side. It's internally rotated, and the hand is kind of going like this. So we call that a waiter's tip. So as if, like, you know, a person is putting their hands towards their backs so that somebody can give them a tip. But it's actually very common, and I see that very commonly. Other problems that can happen is you can have a hemidiaphragmatic paralysis, which means that one side of the diaphragm isn't moving as it should be. And again, if you remember that C3, C4, C5 innervate the diaphragm, then if those nerves are affected, your diaphragm is also going to be affected. And a really nice mnemonic is C3, C4, C5 keeps the diaphragm alive, just so that you know. But another type of injury that can happen is clunky. And again, based on the nerves that are affected, this is what we call a claw hand. So the hand kind of looks like this. And again, babies are not going to have great function of their hands because of the injury at that time. Something else that can happen is something called ptosis, where the eyelid is droopy. You can have meiosis, where the pupils are constricted and they're small. And of course, whenever you have diaphragm injury, then your chest movement and your expansion of your chest cavity is going to be off, right? So those are all really worrisome things that could occur. What should we do for a baby? The answer is up on the screen. But the first thing we want to do is, of course, get radiographs, x-rays. And you want to make sure that the bones aren't actually fractured, because remember, this is more of a nerve injury and not a bone issue. So you want to make sure that the clavicles are intact, the humerus is intact, and there is no fracture to the bones. You do want to immobilize the arm. So usually what we do is kind of have the arm in this position. You can put a safety pin and attach it to the baby's onesie. And you're really gentle. You refer to physical therapy. So having that referral sent in by the pediatrician is really important, because the sooner that you start, the better the recovery will be for baby. And unfortunately, if it persists beyond 3 months, then there's probably not just stretching of the nerve, it could be ruptured or avulsed, and so that will require surgery. But it's not very, very common. All right. So we're done with that baby, right? On to the next one. And I know it still says room 204, but we're going to pretend that's room 205 now. All right. So again, we're gonna go in, and now we have another baby, baby boy B, and we're ready to discharge baby. Baby is 2 days old. Baby was full term. Everything was looking great. Baby's feeding well, voiding, so peeing and pooping well. The pregnancy itself was uncomplicated. Labor, the delivery was really easy. But when we go in, mama is super fixated and worried about this red blotchy rash that she is very worried about. And one of the things as a pediatrician, you have many worried parents, and a good portion of our job is reassurance. Reassurance when that's the thing that you need to do. Of course, we need to know normal from abnormal so that we can reassure parents when things are going normal. And then we can work up things that are not. So here's the baby. So this is the rash that mama's describing. And it looks very red, blotchy, meaning like it's all over the place. In medical terms, what we would describe it as erythematous, so meaning red, macular, which is flat. It's an eruption, and it does have a few 1 to 2 millimeter papules, which are raised, and pustules. So think of kind of like pimples, right? So really small. They're mostly on baby's face, and as you can see, they're on the trunk and the back. We check baby out. Everything else is unremarkable. Baby looks fine. But what do you think this can be? Heat rash, very good. Kind of cold right now. Or eczema, skin irritation, very good. Allergy, What else? Some type of dermatitis, absolutely. Erythema toxicum, awesome. You guys hit the spot. Yes, erythema toxicum. Or maybe just a simple rash due to blankets. Yep, absolutely. So, this is off topic, but parents, sometimes think that babies are cold. And so they're, they have 2-3 onesies, they have 2-3 blankets, and then a huge blanket on top. And so parents can tend to kind of overheat their babies. A simple rash, autoimmune, yes. So this is erythema toxicum neonatorum, and it is a complicated, long name for something that is essentially very benign. Remember, the rest of baby's physical exam was unremarkable. Baby is healthy. There are no red flags. And this is super common. Many, many newborns will have this. So it's idiopathic, meaning we don't really know why this occurs. It's benign, like I said, which means that it's not really worrisome. It's asymptomatic, so it doesn't hurt baby. It's self-limited, which means that it'll go away without us doing really anything. And it usually appears during the first 4 days after birth, but it could also be present right at birth. So, this also, the thing is with erythema toxicum, it can go away and then it can also come back. And so it has parents worried again, but it can just come back during the first 2 weeks of life and it's still completely normal. And let's say, you're worried for some reason and you're not really quite sure if this is erythema toxicum, and you're just, you want to make sure. So this is also a board exam question. If you were to look under a microscope of the contents of the small pustules that were there, you will find a lot of eosinophils for some reason. And that will kind of clue you as to, all right, this is the benign erythema toxicum that you thought it was. All right, this was an easy one. We're super happy. We're gonna discharge baby, one baby off our list. So we go on to the next room. This is room 206 now. And this time we're going to see another baby. And I apologize, there are going to be a lot of baby boys because The WebShadowers logo is blue, and I couldn't help myself. But baby boy C, we're getting ready to discharge him as well. He is an African-American male. He was born at, we'll say full term without complications. He's 36 hours old now. And again, he's been doing really well in the nursery. He's been feeding well, voiding, stooling, doing all the things that newborn babies should do. But again, mama says this time she's noticed that baby has these tiny pustules on his face and they're around his neckline. And again, she's super worried. She doesn't know what this could be. She's a first-time mom and she has never seen this type of rash. So we go on to remove baby's onesie and take a look, and this is what we find. So, just in normal terms, it looks like there's some hyperpigmented or darker areas. There's a little bit of scaling. And in medical terminology, we would describe it as there are 2 millimeter vesicles. You can't really see them here, but we'll say they're kind of like under the chin. And they're white. They're on the trunk, they're on the body, they're on the neckline. But this time there's no erythema or redness with that previous rash. And there's no induration, meaning, the darker areas are flat, and there are several faint brown macules. Again, just very flat brown spots, essentially. And the rest of the physical exam is unremarkable. Again, there's no fever, vitals are appropriate. The rest of baby is absolutely fine. All right, so what can this be? We have a couple of answers. We have baby acne. Sure, baby acne looks a little bit more different than this, but sure. We have, I think it's from mama's milk. Yeah, so that's a different rash where, again, when milk, kind of sits near the neck or any type of folds, it can cause skin irritation. So that could be on our differential. Hand, foot, and mouth disease. Ooh, that's a good one, but we don't really see it on newborn babies. So it is a very common pediatric disease, but we don't really see it on newborn babies. Milk rash, again, very good. That would be on our differential. Freckles, yeah, the darker areas, yeah, they kind of look like freckles. I can see that. You wouldn't really expect the pustules, right? Again, we have eczema, drool rash. Yes, drool rash is also one. Dry skin, blisters. Uh-oh. And then we have transient neonatal pustule melanosis. You guys are awesome. Yes, so that is the correct answer. Transient neonatal pustule melanosis. Again, it's a really fancy term, but we see it a lot. Again, it's very benign. Right, another question, acanthosis nigricans. We see that mostly on older obese kiddos. So you'll see that in the clinic, you'll see that in the adult world, but you don't really see that on newborn babies. So transient neonatal pustule melanosis is benign. It's common in full-term Black infants. And what's interesting is that the pustules can rupture and they leave behind that hyperpigmented or that darker brown macule, that flat rash, and they will gradually fade with time. So again, what if we are, for some reason, still really not quite sure about our diagnosis, and if you were to take a look under the microscope and see the contents of the pustules, you'll see neutrophils this time. So with erythema toxicum, it was eosinophils. With this one, they're neutrophils. And again, we don't really do this. We don't need a microscopic exam. This is a clinical diagnosis. It's very common. We see it all the time. Awesome. You guys are doing awesome. All right. Hopefully this is fun and I'm trying to keep you engaged. All right. Next room. We have a lot of babies to see, so we need to hurry. We're short on time. Ooh, this time it's a girl. And I apologize for changing the color, but I just couldn't help myself. All right, so this is baby girl D. She is 38 weeks. She's AGA, which now stands for appropriate for gestational age, meaning her weight is average. She's a female. She was born to G3P3, so this is mom's third child. Born via SVD, which is spontaneous vaginal delivery. This time it was complicated by prolonged rupture of membranes. And what that is mom's water broke for 18 or more hours. And 18 is the magic number. That is the time where we think this is prolonged and mom is more susceptible to infection, and so is baby. So keep that in mind. That's a clue. Mom did not have prenatal care, unfortunately. And because she didn't have prenatal care, she didn't really know, when she should come in to give birth. And so as soon as mama walked into the hospital door, she delivered. What are the red flags? Just from that brief history that we know about baby. And I gave you guys one. So prolonged rupture, that's the one I gave you. So if mom's water broke for 18 or more hours. Lack of prenatal care, absolutely. So prenatal care is really, really important for both mom and for baby. And so, now with COVID, some mamas have kind of delayed entry to prenatal care. Unfortunately, some moms who are taking substance, who have substance abuse or drugs, they don't really seek prenatal care, or lack of insurance, unfortunately. So there are many reasons why, if moms can't afford it, she probably won't. All right, water broke 18 hours, yes. Infection, yes, so risk of infection, absolutely. Low oxygen, don't understand what you mean by low oxygen. Delivery wasn't monitored, right. And do you guys think precipitous delivery is a red flag? So precipitous means that it happened quick. So it wasn't controlled. Mama didn't have a proper exam. Eclampsia, lack of folic acid for neural tube defects or development. Lack of nutrients for baby. Oh yeah, very good. So nobody was there to monitor mom's, nutritional intake. They couldn't monitor her weight. Absolutely. Intake of harmful substances. Right, we don't know. She could have been taking harmful substances and we don't know. So those are all really good, well, really bad red flags, but great answers. All right, so now baby's exam. So again, we see what looks like pustules, right, or vesicles. So vesicles are fluid filled, and they do have an erythematous base. So kind of sort of similar to erythema toxicum, where there's redness on the base, and then we have these here are these vesicles. But this time we're describing it as clustered, meaning they're grouped together, right? They're not blotchy, they're not spread out. These are grouped clusters. So in this case, what do we think is going on? What can this rash be? HPV. So HPV usually will have more of like warts. So warts are, the top of them are kind of ugly looking. Not that these are pretty, but these are more of a smooth. Gonorrhea, ooh, yes, absolutely. That's on our differential. Infection, yes. Staph, yes, absolutely. Staph infection, again, yes. Transplacental syphilis or another STD. Again, mama didn't have prenatal care. We don't know. She wasn't tested. maybe some sort of vitamin deficiency. Yeah. MRSA. Yes. Awesome. You guys are great. What else? Some type of bacterial infection. Impetigo. Oh, that's a really good one. That's a very common pediatric rash. We kind of describe it as honey colored. And so you'll see kind of oozing, it's crusted. Yeah, this kind of looks crusted. Let's just say that those vesicles ruptured. Eczema, hives. All right, you guys ready? Bullous pemphigoid. Ooh, very good. Awesome. That's a really nice one. So those are kind of blisters where they could rupture, they can staph infection, skin lesions. Yes. So I'm going to go quickly because we have a lot to get through. So baby girl D, neonatal HSV or herpes simplex virus. So why is this one different from the rest? Because this infection can cause serious morbidity and mortality. It's devastating for an infant. And many of these infections will result from asymptomatic shedding of the virus. So mama doesn't know that she has herpes and the virus is shedding and she really doesn't quite know, or maybe she didn't have prenatal care or nobody has checked to see if she has genital HSV or herpes. So if mom has an active infection, so meaning you see lesions in her GU area at the time of the delivery, we will not do a vaginal delivery. We will go ahead and perform a cesarean. But most neonatal HSV infection can be devastating, and that is why it's really important to distinguish this between this and the other rashes. So most of these infections are caused by HSV2. So there are two types. There's HSV1, where we primarily think of as the one that causes cold sores on the lips. And we primarily think of HSV2 that causes genital lesions, but that's not black and white. So most cases will occur during the intrapartum period, but they can occur in utero, so when baby is still in mom's womb, or it can baby can contract it postnatally. So if they touch vesicles that are on parents or on another caregiver, then baby can be infected that way. And if babies have congenital HSV, then they can be born prematurely, they can have low birth weight, and they can have many risk factors. So there are usually 3 different types of clinical case presentations for neonatal HSV. One is if the disease is just localized to the skin, the eyes, and the mouth. Another form is encephalitis, and that's when, unfortunately, the virus causes infection in the brain. That could be with or without other involvement in the skin and the eyes and the mouth. And the worst one, as you can imagine, is disseminated infection. And that's when the virus goes to multiple sites. It can go into the central nervous system. It goes into the liver. Again, multiple sites. And unfortunately, that one has the highest mortality risk for a baby. And again, the reason why I wanted to put this in is because, again, it's very serious. And even if you're not working in the nursery, if you are seeing pediatric patients in general, any newborn, so in that first month of life, if a baby comes and has a fever and very non-specific symptoms, so doesn't really have anything else going on, maybe just some poor feeding, baby's not really waking up as often, or baby has a seizure, you need to consider HSV. And the reason why is because, again, if you start baby on antibiotics, that's not the proper treatment. So you always need to have HSV on your differential. And again, if you see any vesicular rash, meaning you see the fluid-filled vesicles that are clustered, grouped together with a red base, always think of HSV. And immediately start baby on antiviral therapy with acyclovir, pending culture results, right? So you start it, you can always stop it if it comes back as negative. But again, because it is so deadly and it can cause morbidity, start the treatment. What else do we do to confirm? Well, we're going to get blood culture. So we're going to take blood sample, send it to the lab. We're going to get CSF, meaning we're going to perform a lumbar puncture. We're going to take some of that CSF and also take a look at it under a microscope, or you can even send for PCR, which is much, much quicker. We're going to take a urine sample, and then we're going to take fluid from the eyes, the nose, mucous membranes, nose, the mouth, all to look for HSV. And again, remember to start acyclovir. And if baby has just that limited disease, meaning it's just on the skin, the eyes, and the mouth, then you can go ahead and use 14 days of therapy. But if it's passed on to the CSF, and now we're talking about encephalitis, then that's going to be for much longer treatment. All right. Wow, guys, again, we have so many babies to see, so we're going to go to room, I've lost count, maybe 207, maybe. And then we have another baby girl E. So this time she's 2 days old. She was born, again, at term. She's full term, uncomplicated pregnancy. And before babies leave the newborn nursery, we always get a hearing screen. So she underwent a type of hearing screen called an ABR, which we'll talk about in a little bit. And that's part of the nursery's protocol. But unfortunately, she did not pass. One of her ears did not pass. What are some causes of hearing loss that we need to be thinking about? And we need to go a little bit quicker. I'm taking my time with this. We have so many other things to cover. Hopefully you guys are interested and this is fun. So what are some causes of hearing loss? Genetics, yes. So usually we think of, family history, early birth, yes. Prematurity is absolutely a risk factor. Prematurity, guys, is a risk factor for many things. So if you say prematurity for any risk factor, it's probably going to be right. Infection, absolutely. Amniotic fluid stuck in ears, yeah, so that's actually a real thing. And blockage, right? So if there is some fluid, it's going to mess up your screening exam, right? And so most of the time, that's what it is. And we have our hearing screeners repeat it. Repeat the hearing screen maybe a couple of hours later, or maybe the next day if baby hasn't left yet. Iatrogenic-like drugs. Oh my gosh, you guys are awesome. Yes, like aminoglycosides. So if we, for some reason, started baby on antibiotics like aminoglycoside, yes, it is ototoxic, meaning it is not good for hearing. Underdeveloped hair cells for some reason, yes. Temporal lobe issue, yeah. So CNS or central nervous system problems. Unformed tympanic membrane, yeah. So for any reason, the baby's ear structure did not develop appropriately, it can absolutely cause that. Oh, I saw a really good one, meningitis. So anytime you have infection, that can absolutely cause it, nerve damage. All right, so you guys already got this. So we talked about genetics, we talked about infection, prematurity, low birth weight, medication side effects. And the reason why we worry so much about hearing loss is because, remember, you're taking care of this newborn baby And whatever you do here, it's going to impact baby's life, right? And so if you're able to pick up on hearing loss and you're able to start baby on treatment, on therapy, speech therapy, or whatever it is, and you can correct some of the reasons, then you have set up baby for success, because a lot of baby's development is affected by hearing, and so especially speech. All right, so this is a question. So now that baby, we repeated the test and baby still did not pass, what are we going to tell mom? So are we going to tell her follow up with her pediatrician, retest only if she develops signs of hearing loss? Are we going to go ahead and just refer her for more audiology testing, only if she has family history of hearing loss? Or are we going to go ahead and refer for testing before 3 months? Or are we going to say she's already failed it, let's go ahead and get her fitted for a hearing aid? What do you guys think? All right. Not quite D. Yes, the answer is C. Many say C. Yes, you guys are awesome. So remember, this is a screening test. So it doesn't mean this is 100% accurate, right? And so anytime you have a screening test, you can confirm. So we tell mama and we tell baby's future pediatrician, baby did not pass the newborn hearing screen. Baby needs to be referred for formal testing. And usually the cutoff is before 3 months. Remember, the earlier the better, because we want to say, you know, if baby, we don't want babies to go on for longer than 3 to 6 months before we know if baby is able to hear or not, so that we can start the appropriate interventions. So you guys are excellent. Answer is C. All right. We're not going to go too much into depth, but there are 2 screening methods that we use. It's like, how do we know babies can hear? They can't raise their hands. They can't tell us. Yes, but we have 2 methods that we use. One is where we play different sounds and different tones through an earphone, and then the electrodes that are on baby's head will actually measure the brain's response to the sound. The other one is the OAE, and this one is similar but not quite. So this is where we also send different sounds, and then we measure the response or the echo back. When that echo response comes back, we know that there was proper signal. So these are very quick. They're painless. We do want babies to be cooperative, so we usually will feed baby, swaddle baby, make sure they're nice and quiet, and we will get the test done. All right, next. All right, baby boy F. We're back to baby boys. So this time we're about to go into room 208, but the nurse runs up to us and says, hey, we need you urgently back to the newborn nursery. We have a baby with respiratory distress. Baby is not breathing well. So as we're all running, all 100 of us are running to the nursery, we're asking nurse, give us baby's history. And she says, baby boy was born at 41 weeks. He was born via emergency C-section for non-reassuring fetal heart tones, meaning baby's heart rate was just not quite right. And, ooh, that's my daughter. So if you give me 1 moment, I'll be right back, you guys. Yes, Hannah? All right, guys. Sorry about that. I had bribed her if she stayed quiet that I would give her a snack afterwards. All right. So Where were we? All right, so baby is having trouble breathing, rupture of membranes. Again, mom's water broke for a long period of time. This is not 18 hours, this is 28 hours prior to delivery. And it was meconium stained. And meconium is that first poop, baby's first poop. And when mama's water broke, we saw baby's poop there. And again, this is getting worse. Delivery was complicated by maternal fever. So mom had a fever and she had an intra-amniotic infection. Oh, you guys are sweet. All right, so what are some signs of respiratory distress? We get there to the newborn nursery and we see baby. Baby is grunting. So that's when, baby's making that sound like tachypnea, meaning breathing fast. So baby is breathing more than 60 breaths per minute. Baby has retractions or using muscles to help baby breathe. There is nasal flaring. So that's when baby's nose is flaring or widens, trying to get more air in. Baby has hypoxia. So when we put the pulse ox, we see that the oxygen level is low. We see cyanosis or blue, let's say around the mouth. So these are all really, really terrible things. What is going on? What is our differential? So anaphylaxis, lung infection, meconium aspiration, intubate. All right, so we didn't talk about red flags, but the whole history was full of red flags, right? Fecal infection. So yes, what baby has is meconium aspiration syndrome. And again, because we're running out of time, I'm not going to go through everything. I'm just going to talk about what this baby has. But you guys, again, we're right. Meconium aspiration syndrome. And this is what happens when, for some reason, during delivery, baby is stressed, right? Because if you remember, this baby had non-reassuring fetal heart tone. Baby's heart rate was not reassuring. So baby was stressed. And what happens when babies are stressed is that they can pass meconium, that first poop, that first stool, before the delivery. And what happens is as baby's delivered, they can sometimes gasp. And when they take that first breath, they can aspirate some of that meconium, that poop, into their lungs. And guys, if you haven't seen meconium, you won't know what I'm talking about, but meconium is super sticky. You need like a whole thing of baby wipes to get it off. Like, it's super sticky. It's like a dark green, black color. And imagine if that gets into baby's tiny airways. It's going to clog your airways. It's going to irritate it. It's going to cause lots of inflammation, more swelling, right? And what's worse is that meconium also blocks surfactant. Surfactant is what helps open up the tiny alveoli, those little grape-like structures, and helps keep them open. So if you don't have surfactant, those alveoli in the lungs are going to be closed. Imagine how much it's going to take to open them back up, right? So this is just a setup for lots of bad things to happen. So what are we going to do? We're going to, of course, we're going to examine baby. We're going to try to stabilize baby. We're going to use oxygen. We're going to send baby to the NICU right away. We're going to keep going because there's a lot we can say with respiratory distress, but let's keep going because we have a fun one coming up. All right, this one, baby boy G. So we've stabilized the other baby. NICU team is coming. Now, as we're about to leave and round, we're called again urgently back to the newborn nursery. This time we have a baby with green vomit. And again, you may be thinking, so what? Vomit is mostly green. Like, no. So babies with green vomit is very dangerous, and we'll talk a little bit about that. So this time it's baby boy. He's 24 hours old. He was born at 38 and 6, C-section. Mom says that the baby hasn't really been feeding well. Baby's vomited after each of his last 3 feedings. And so every time baby takes a bottle, vomits right back up. And it's not white. It's not formula. It's green. So what is going on? What do we think is going on? Or as we're running back, what are some of the things that we want to ask? Bile, yes. We want to ask, describe this vomiting. How much is it, right? How does it look like? Does he have an allergy? Yeah, absolutely. That could be on our differential. All right, so you guys told me that we worry about bile, right? If it's green, we worry about bile. So bilious emesis, we talked about that it's due to vomiting of bile. And the reason why we worry so much is because it often indicates some type of obstruction. So if you take a look at the photo, you have the gallbladder. So bile is made and then it's stored in the gallbladder. And you have the common bile duct, you have the pancreas, and then you have the ampulla of Vater, which brings the bile and the contents of the pancreas into the duodenum. So if you have an obstruction past that, what's going to happen? That bile is going to back up. And if you're going to throw up, it's going to be bilious or green. So this is a true emergency, and it does require surgical intervention if it happens. So first thing we're going to do is assess the patient. We're going to quickly run to the nursery. We're going to look at baby's vital signs. We're going to assess hydration, because remember, baby has been vomiting for the past 3 feeds. And babies, it doesn't take much for them to lose hydration. We're going to check, of course, their belly, right? We're going to see, is it distended? Is it like full? Does baby have organomegaly, meaning that the liver or spleen are large? Can we hear bowel sounds? Are things moving? Are things moving too quickly? Anytime we touch it, does baby have tenderness or pain? Is baby guarding? And our differential, again, is going to include lots of obstructive lesions that we are going to quickly go over. The first one, so whenever I hear bilious emesis in a newborn, I am worried about something called intestinal malrotation, with or without volvulus. And basically, long story short, during the baby's development, the bowel undergoes 2 types of rotations, okay? If they don't rotate properly, what happens is you can have obstruction, or you can have, as that picture shows, volvulus. Like, look at that. Everything is kind of, twirled around each other. And that's a surgical emergency, because if you can imagine, if you lose blood supply, right, to that area, that bowel is going to die. So we have to be quick. So what do? Whenever you hear that, quickly get an upper GI. And what that is a procedure that helps take a look at the anatomy, right? So we give baby fluid called barium, and it's going to coat the lining of the intestine, the stomach, and it shows up white on X-ray. So we can get a really good picture as to what is going on, right? So back. So if we see this, baby needs to go for surgery, and we need to help make sure that that bowel does not die and necrose. All right, other things that can cause obstruction and therefore cause bilious vomiting. One of them is duodenal atresia. Again, some babies are born with, unfortunately, a malformation along the GI tract, and this time there is a small segment of the bowel that's very narrow. So this is a really nice picture that shows you the site of atresia. It could either be very narrow or it could not be there at all. And of course, if that happens, there's going to be obstruction. Another disease is Hirschsprung. You may have heard of it. This time, what happens is there is an absence of nerve cells in the bowel, and the bowel is therefore contracted, right? And it's not able to relax because the nerve cells aren't there. So if it's contracted, as you can see from the picture, then everything above it is going to be wide, right? It's going to be full, distended, and that's a type of obstruction. And we can help diagnose that by something called a contrast enema. So we take, again, contrast material, we insert it through the baby's rectum, and that shows up again on fluoroscopy, and it can show us that there is an area of bowel that's constricted and another area that's normal, and that could clue us in as to her sprung. The definitive diagnosis, though, is you need to actually go into surgery, get a biopsy of that bowel, and take a look at it and make sure there are no ganglions or nerve cells. And so that is the definitive diagnosis. But again, treatment is surgical. And that's why bilious emesis is very important to know about, because it's very time sensitive. All right, so what are we gonna do for baby? We're gonna say, make patient NPO, so we're not gonna feed baby. We're gonna decompress the GI tract, so we're gonna put in an NG tube or a nasogastric tube. It's gonna go through and remove things from the tummy. We're going to, of course, get IV access because baby needs hydration, right? We're gonna start fluids. We're gonna check labs just to see where we're at. We may even start antibiotics if we need to. All right, do we have time for one more? All right, last one. So baby boy H, baby is full term, 39 weeks. He's born to a G2, P2 mom. So mom's second baby, and uncomplicated spontaneous vaginal delivery. And we go in and we see baby look like this. So what's wrong with this baby? This one's quite obvious, right? He's cute though. I think it's a he. So baby looks yellow, right? Can you guys see that? Baby looks very yellow. All right, so what is going on? So baby has jaundice, or kind of that yellowing from the skin. Yes, you guys are awesome. So what is jaundice? And parents will ask you this question all the time. So basically we say that the red blood cells break down and they release something called bilirubin. It's a pigment. That's what causes the color. Most of the time, it's processed by the liver into a form that can be removed from the GI tract. But because babies have a lot more red blood cells than we do, and their lifespan is a lot shorter, this all means that baby's breaking them down more quicker and has a lot more to break down. So the risk of having hyperbilirubinemia, or a lot of bilirubin, is a lot higher, right? And even then, the liver is not really mature yet. The enzymes haven't started working as well. So they aren't able to get rid of the bilirubin as quick as we want. The reason why we worry, it's not so much about the yellowing of the skin. It's because high levels of bilirubin can cross the blood-brain barrier and cause a serious condition called kernicterus, which is a form of brain damage. But thankfully, we don't really see that now, because we are able to check babies' levels in the nursery. We're able to know ahead of time who will be a higher risk, and we have something called phototherapy. So let's say that this baby has something called Abo Incompatibility. This is a super fun one. So this is going to be the last thing we do, but super fun. So mom has a blood type, right? Let's say if mom had type A blood, then she has A antigens on her red blood cells, and her plasma will have antibodies against B. If mom has type B, then she has B antigens on her red blood cells, and her plasma has antibodies against A. What if mom has type O? So she has no antigens on there, so she'll have antibodies against type A and against type B. What if she has a baby with, let's say, type A? Mom has antibodies against type A. So what might happen? Well, you may have hemolytic disease of the newborn, where because of this incompatibility between the blood types, some of the maternal antibodies will leak into baby's bloodstream and start attacking baby's blood cells, red blood cells. So if that happens, what do? We, of course, are going to monitor baby's bilirubin level very closely. And most likely, we're going to start phototherapy, which is light therapy. And what happens is that blue light will convert the bilirubin into a different type, a different form that the body can get rid of through the urine. And for some reason, if the levels are extremely high, then we can do something called an exchange blood transfusion. And I did this during my intern year of residency. I'll never forget it. It is so time consuming. And basically what you're doing is you're removing small amounts from baby's blood. At the same time, you're replacing it with fresh blood. So imagine doing that. It takes several hours, and you have to be super careful, and you have to monitor baby, and it's just very time consuming, but rarely it does happen. All right, guys. Whew, I don't know about you, but I'm already exhausted like that. We've seen crazy newborns. I hope you guys like that. Honestly, I'm sorry that we went a little bit over time, but my last word of advice for you is that what you're doing right now is extremely difficult. I know it's difficult, but if you have that goal in mind, that you want to become a physician, whatever specialty it is, keep moving towards it, and you'll eventually reach it. I did, and I'm sure all of you will as well. If you guys want to reach me, you can find me on Instagram, or you can email me. I don't check my email that often, but I do once in a while. But you guys, I hope this was beneficial. I hope this was interactive. I hope you had fun. I really did. And if you have any last minute questions, I don't mind answering them as well.
Thank you so much, Dr. Ramadan. This was such a wonderful presentation. It was so interactive, and thank you for providing us with so many cases.
Absolutely. There's so many.
Additionally, thank you all for attending. The link to the Google form for this session has now been posted in the comments, so please fill it out within the next 30 minutes for us to receive your verification. Again, thank you so much, Dr. Ramadan. We loved it.
Thank you.
Absolutely.